Welcome back. Having covered all the kind of background information to pharmacology, that is, what's pharmacodynamics, what's pharmacokinetics, what are receptors, how do drugs interact with receptors, we're now going to move on into a sequence of lectures where we look specifically at different aspects of the functions of the body and how drugs interact with those. And we're going to start with the rather broad topic of the autonomic nervous system and drugs dealing there. So the autonomic nervous system, that's basically about controlling the homeostasis, make sure the body is responding in the way that it needs to. So cardiovascular function, respiratory function, digestive function, etc., etc. You probably also have heard of the concept of dual innervation. That means that the organs and systems of the body being innervated by both arms of the autonomic nervous system. So it's sympathetic neurons and parasympathetic. That's the two arms of the autonomic nervous system. Sympathetic neurons releasing noradrenaline to produce the effect. Parasympathetic releasing acetylcholine to get the desired effect. Sometimes the sympathetic with the noradrenaline is referred to as fight or flight, with the parasympathetic being referred to as rest and digest, because it's more involved in gut control. So sympathetic is going to be, if you like, driving a system, and parasympathetic is about reining it in. Okay? For example, sympathetic neurons will drive the heart, parasympathetic will slow the heart down. Looking at this diagram here though, what we've got is all of the neurons coming off the, if you like, the spinal cord and feeding out to the body. And on one side we've got all the neurons that are feeding into the sympathetic pathways. So, I suppose the thing is, just to do a quick comparison of the two, you have sympathetic input to the heart, the lung, and you've also got parasympathetic input to the heart and the lung. Input to the liver, the spleen, the stomach, liver, spleen, stomach, intestine, colon, kidney, yeah, rectum, bladder, genitalia. So that's clear evidence and indication of that concept of dual innervation. So with sympathetic causing the system to do one thing and parasympathetic causing it to do the opposite. Looking at the autonomic reflexes then and the autonomic pathways, what we're looking at here is, if you look at this diagram here, then if we ignore the top line to start off with, the one that's called somatic, because that somatic one there is basically your motor neurons that are going to go down, release acetylcholine onto nicotinic receptors, causing the contraction of skeletal muscle. So that's a kind of, if you like, a separate entity. We've then got the sympathetic and the parasympathetic. That's the two middle sections here. Now, following the main pathway, sympathetic, you've got the neurons coming from the central nervous system down the way. You then get the ganglia, where there's the main connection in the pathway. Now, at the ganglia, although this is sympathetic, which is also ultimately going to release noradrenaline, at the ganglion, the preganglionic neurons always release acetylcholine, and that works on a nicotinic receptor. That's true of parasympathetic, where the end point is acetylcholine release. The pre to post ganglionic transmission is also nicotinic cholinergic. So, although we tend to think that the sympathetic over here is releasing noradrenaline, ultimately it is, but the link in the middle is always nicotinic, and that's true is the same of the parasympathetic here, releasing acetylcholine at the end, but it's also releasing acetylcholine at the middle to get the desired effect at the ganglion. But the bottom line is, regardless of the fact that the ganglionic connection is the same, it's the terminal part that's different. Sympathetic release noradrenaline to work on alpha 1, alpha 2, or beta 1 and beta 2 adrenal receptors. Whereas parasympathetic release acetylcholine to work on muscarinic receptors when you've got the dual innervation. This is a rule. However, as with all rules, there is always an exception. The exception to this rule is this bit here. And that is that when the sympathetic nervous system activates here, it also causes acetylcholine to work on muscarinic receptors in the sweat glands. That's because, if you think about it, you'd be switching the sympathetic on to release noradrenaline, to work on adrenal receptors, for example, during periods of exercise, to drive your heart. When you're driving your heart, when you're physically active, your body would overheat. What do you need to do to control temperature? You need to increase sweat production. Sweat glands contain muscarinic receptors, but they need to be activated, if you like, simultaneously with the sympathetics, so that they go hand in hand. So that's the exception to the rule. Other than that, everything, the terminal part of a sympathetic pathway is always releasing noradrenaline, and the terminal part of a parasympathetic pathway is always releasing acetylcholine. Now, if that's the basic thing, you can then start to manipulate and alter the system by giving agonists and antagonists that will work. So you've got your endogenous transmitters, noradrenaline for sympathetic, acetylcholine for parasympathetic, but then you can introduce agonists and antagonists to either enhance or reduce the effects of those endogenous transmitters. So you can facilitate it, you can block it, you can do that at the level of the ganglia, you can do it at the terminal, you can block the receptor by giving an antagonist, you can stimulate it by giving an agonist, all sorts of permutations and combinations that will ultimately give you the desired effect that you want. So you've got this dual innervation. So for example, you've got the heart that's being driven by the sympathetic and slowed by the parasympathetic. If you've got high blood pressure, then what can you do? You can either switch down the sympathetic or enhance the parasympathetic. And this is just a little diagram to show you how that comes about. Basic neuron releasing a transmitter going to go and work on a receptor. How can you facilitate the transmission? You can either make more of the transmitter, you can increase the level by stopping the degrading enzymes, breaking it down. You can bind to presynaptic receptors which are inhibitory, which would stop further release, and if you block them, you don't stop the further release. And then you can bind to postsynaptic receptors and you can activate them with an agonist. Also, once they come off the receptor, there's enzymes in here that break it down, block the enzymes that break it down. All of those things will facilitate neurotransmission. Over on this side, if you want to inhibit transmission, you can block the synthesis of the transmitter, you can block the release of the transmitter, you can activate the presynaptic receptors to reduce the release of the transmitter, or you can block the postsynaptic receptors with an antagonist. A multitude of ways that you can interfere with a system when you know that what you've got is a transmitter being released, transmitter being working on a receptor, coming back off, being broken down and being cleared away. And this is just another little diagram, different look to it, just showing you the exact same thing. Okay, so I'll just leave that up for a few seconds just for you to have a look through, and you'll see that what that does is, that basically explains the exact same as what we looked at in the previous diagrams. So, thinking about these compounds, when would you want to interact with these receptors? We've said at the terminal part of the, at the ganglion, you've got these nicotinic receptors. Is there any value to giving a nicotinic agonist? Actually, they've no clinical use whatsoever because they're not selective enough. If you give a nicotinic agonist to do something at the ganglion, they will also work at the nicotinic receptors that are found at the skeletal muscle. You can't get the exclusivity that you need. they're not really used then clinically, but they can be used experimentally because they will facilitate the activity of sympathetic and parasympathetic pathways at the level of the ganglion. If you wanted to enhance something in order to test another, like a receptor interaction at the terminal part of the pathway. So they have an experimental use, but not clinical use. Here's another example with how you get with the noradrenaline. Presynaptic neuron produces noradrenaline. It gets put into a vesicle and it gets released. It goes across, it works on its receptor. As we said previously, the adrenal receptors are G protein linked. They activate second messengers and produce their effect. You've got enzymes that help synthesize the noradrenaline. You've got agonists and antagonists to work on the various receptors. You've got drugs that will affect the reuptake. All sorts of different ways to manipulate either the amount of noradrenaline being produced, the amount of noradrenaline being released, the amount of noradrenaline that works on the receptors, and the amount of noradrenaline that gets taken back up. And that's true for all transmitter systems, that you can manipulate and interact in this way. You saw in the previous diagram that we've got uptake 1 and uptake 2. Uptake 1 is when the neurotransmitter is taken up back into the presynaptic terminal that made it. So back where it came from is uptake 1. But you've also got uptake 2, and that's where there are other tissues in the area that will take it up. But both uptake 1 and uptake 2 reduce the amount of neurotransmitter that's found in the synaptic cleft. That's the key thing about it. So here's some examples of the various receptors that we talked about. So, alpha 1, if you activate alpha 1, there's the effect you get. So what we've got here is, we've got adrenal receptor, we've got effect, we've got the agonist that works on that receptor, and we've got the clinical effect that you would have. Okay? So alpha 1, arterial smooth muscle. Alpha 2 inhibits noradrenaline release. Okay? Therefore would be useful in the treatment of hypertension because it would reduce the amount of noradrenaline being released. Beta 1 increases rate and force of heartbeat. Dobutamine is an example. So if there's heart failure, this would drive the heart better. Beta 2 agonist, salbutamol. Beta 2 smooth muscle in the airways. Relaxes smooth muscle, therefore gives you a bronchodilation, useful in asthma. Thinking about it from an antagonist perspective, alpha 1 antagonist, a drug like prazosin, can be useful in the treatment of gives you hypertension. Alpha 2 is not really used clinically. Beta 1, a beta 1 would normally drive the heart. If you give a beta 1 antagonist or a beta blocker, it will reduce the workload and therefore lower the blood pressure. And beta 2 blockers, beta 2 normally relaxes smooth muscle. If you block the beta 2 with a drug like butoxamine, you would get bronchoconstriction, for which there is no clinical use whatsoever. That's all been the sympathetic. In the parasympathetic, it's acetylcholine being released, and acetylcholine works on the muscarinic receptors at the very end of the parasympathetic pathway. So looking here, you've got M1, M2, M3 and M4. That's the 4 subtypes of muscarinic receptor. So here we're not looking at muscarinic agonists, we're looking solely at muscarinic antagonists. If acetylcholine works on a muscarinic M1 receptor, that will cause increased gastric acid secretion. If you give pirenzepine, which is an antagonist, it will reduce gastric acid, therefore has a clinical use. M2, when acetylcholine works on M2, the pupil is constricted. If you give the antagonist for M2, it will do the opposite and give you pupil dilatation. M3, when acetylcholine works on M3 itself, it increases smooth muscle tone. If you block it, that can become an antispasmodic agent. And again, M4 is a bit like the M2. M4 causes constriction of the pupil. If you block M4 with tropicamide, you will get dilatation of the pupil. So this was just a brief introduction to the autonomic nervous system, because we will come back and look at that on numerous occasions in the future, particularly looking at the adrenal receptors and the muscarinic receptors when we're talking about the cardiovascular pharmacology in a few lectures' time. What you need to get from today, though, is this idea of sympathetic ultimately releases noradrenaline to produce its action via adrenal receptors, and the parasympathetic ultimately releases acetylcholine to produce its action via muscarinic receptors. But at the ganglion, or the connection in both of those pathways, the connection is always, if you like, supported by acetylcholine release working on nicotinic receptors. Thank you.